Wonderful, and wouldn't you agree that Melanie Bella did a terrific job? Yeah, she's still here. But one of the highlights really is to hear from our own experts, from Missouri experts in these areas. And so today we're delighted to have an expert panel that you see before you. Couple housekeeping items. I know earlier some of the slides were a little bit hard to see, and I just would like to remind you that all of the talks will be up on our website. You have to give it a week or two, probably after November 8th. But again, that's www.healthpolicy.missouri.edu. So if you miss some of the slides and really want them, they'll be on our website for you. First of all, I'm going to introduce the panel, and then I'll just do a little brief intro to the topic. First, we have Dr. Michael Ditmore, who's the Director of the Division of Medical Services at the Missouri Department of Social Services. Dr. Ditmore is responsible for the overall administration of this $4.8 billion program. And as many of you know, he's a retired neurosurgeon from Columbia. So we're delighted to have him today. Dr. Ditmore will be followed by Donna Checkett, who's Senior Vice President for Medicare and Medicaid at Schaller Anderson, and also CEO of Missouri Care Health Plan, which has over 35,000 healthcare providers. Donna's former director of the Missouri Division of Medical Services. You can see this a little bit all in the family. We also, third, we have George Astrike, who's the director of the pharmacy program at the Missouri Division of Medical Services. For those of you who don't know, that's Medicaid. That's where Medicaid is. And George has directed that program since October of 2001. So he's going to come and talk to you a little bit about pharmacy and Medicaid, which is entirely appropriate, as that is the largest expenditure in the program at $1.2 billion. So fitting that we take a special look at pharmacy. Steve Rolling is next. He's president and CEO of the Healthcare Foundation for Greater Kansas City. And we're delighted to hear from him. He is a former director of the Missouri Department of Social Services. And for those of you who don't know, Division of Medical Services is underneath the Department of Social Services. And then Dwight Fine is going to finish up for us. And Dwight, many of you know, is Senior Vice President for Government Relations at the Missouri Hospital Association. And you know, you might say he needs no introduction, and so he's going to be our finisher. Before we get started with the panel, one of the things we've learned from doing these summits is a lot of the folks in the audience know a lot about these topics, but there are always people who don't, honestly. And so just to make sure we're kind of all on the same page and we know how we got here, I thought I would just run through a few general topics about Medicaid in Missouri. And before we get started, I want to remind you that this is a policy discussion. You know, there's been a lot of political stuff from both sides of the aisle, and that's not what this is about today. This is about looking to the future and seeing how we can make a better program. Just for those of you who don't know, Missouri has historically been a very generous Medicaid program, and you can see the number of enrollees there over the last 15 years, up nearly 1 million. There's the appropriations. All you have to see is the slant of the graph there. Total appropriations just going up and up and up over the last 15 years. You know, here's the budget. Most state budgets are like this, and all you have to see on this is the left red piece of the pie is human services, and Medicaid's the big chunk here. And that's why we had the changes in the Medicaid program we had. That's why our elected representatives were forced to make cuts that you've heard a lot about because of this stress on our budget. And it's not going to get any better either, and so that's why this discussion today is of critical importance, because we're going to have these challenges again. This isn't just what's happened in the past, it's what we're going to be looking for in the future. Just looking at types of expenditures in 05, you see pharmacy there at $1.24 billion, you know, which is a lot more than what we spend in hospitals, nursing homes, and managed care even. So just for those of you who don't know that, that's not the same in every state, but that's where we are in Missouri. And then you all know this, I do believe, that children are over half of the enrollees but account for only 20% of the expenditures. And some people may say, well, why did they cut, you know, why were disabled and elderly people cut off the program? And that's why. 2/3 of it really is elderly and disabled. So the reforms, just for your interest, if those of you who don't know, eligibility changes, benefit package changes, regulatory requirements, and increases in copays and premiums. Parents of eligible children went from 75% of the federal poverty level to roughly 24%, and income limits for the disabled were from 100% to 85%. Who cares about this? Who does it matter to in Missouri? Well, everybody does. There are some counties down in the southeast part of the state where a large percentage of the citizens are participants in the Medicaid program. But in terms of absolute numbers, the urban areas have the highest absolute numbers. So really everyone in Missouri cares about this program. So the question today for the panelists is, how do we start from here, given that which is passed, given the budget constraints that are very real and aren't likely to go away? How do we build a sustainable program of quality care for our most vulnerable citizens? So we're going to start with Dr. Michael Ditmore.
I really shouldn't correct Dr. Edison, but she uses the term expert quite loosely because I know myself and I know these other panelists pretty well. I might also point out that between Donna Checkett, Dr. Astrike, and Dwight you have a huge piece of the budget that I'm supposed to be overseeing each year. The future of Medicaid in Missouri. Let me just go back and sort of tell you where it's been traditionally. And traditionally, from the very start, Medicaid was a payer. You wanted to go to dinner that night, you were a provider, you sent a bill into Medicaid, and you got paid. It usually wasn't enough to pay for your dinner, but at least it helped. We think that the future of Medicaid is to change that passive participant that Medicaid has been in the past. You also, I'm sure, all know that we had mandatory eligibles or mandatory groups. Those are a reflection of when Medicaid started. It emphasizes the elderly and children. Medicaid also has mandatory services that we have to provide. Once again, the Medicaid program emphasizes eligibility groups and services. And frankly, we think we need to change this and begin to look at Medicaid not only as just a payer and giving services, but in fact identifying disease processes and paying for treatment of particular disease processes rather than just the services. Medicaid optional eligibles, this reflects the changes from Senate Bill 539 this year. Medicaid optional services, you'll notice that pharmacy is an optional service. Now, we've had it for some time, but it is, in fact, an optional service. Psychiatric services and mental health are optional services that we provide. Again, Medicaid has been a payer. The only way to cut cost was to decrease services or cut eligibility. And that's been the response in the past if we needed to save money, and that's what happened this year. We believe that the only way to get true cost savings long term is to bend the trend line of increasing costs by the way we administer the program. And this reflects the total growth in Medicaid costs, and you'll notice that in 2005 there's a little dip down from the cuts that were made, but the trend line in all of these areas is the same as it was. You really haven't changed that trend line, and within a couple of years we're going to be back just where we were and continue upward unless we bend this trend line down. You'll notice also that the disabled and the elderly are a huge part of the cost. Children and adults are not a big part of the cost of Medicaid. And this is a visual representation of how we think we need to go forward with bending this trend down and how we need to use Medicaid to improve the quality of life of the recipients and at the same time cut the cost. We think that for those people, those few people who use most of the resources, we need to do some intensive care management. And we'll go through the chronic care improvement program, which I think sort of illustrates where the direction we want to go with Medicaid in the future. Using the savings from that chronic improvement program, we want to concentrically go out earlier and earlier in the process to bring these people into more intensive case management so that they don't get to those more expensive treatments and require the increased resources. Why are we interested? Because Medicaid provides the medical coverage for most of the vulnerable individuals in Missouri. Medicaid, unlike private insurance, have these recipients and patients for most of their lives, and many recipients have chronic diseases that do in fact require significant management and treatment if we're going to keep them out of the hospital and out of the ER. Generally, with the Chronic Care Improvement Program, we want to improve the health care status of the recipients. We want to coordinate the coverage and help with guidelines, et cetera, to make some of those coverage decisions. We think there will be significant short-term savings, but we think even greater will be the long-term savings because we'll keep the diabetic out of the dialysis unit for a longer period of time. We think that there will be more preventive care in this program, and that will lead to even more long-term savings. Generally, the Chronic Care Improvement Program that we've suggested is an amalgam of disease management, care coordination, and case management with enhanced primary care case management. And it'll use a population-based identification and intervention based on that population. Most of you could name the diseases that we're talking about that are the high resource users. I won't go through all of these, but we're looking for the ones that have multiple comorbidities, which many of these people do, not in this group, but a significant cost to Medicaid, and a significant driver of some of these processes is that a huge number of Medicaid recipients have mental illness. And we've got another program that works on that to some extent, and we've had some demonstration projects. I think Dr. Astrike may or may not talk about that a little bit. Candidates will be identified primarily through the claims paid data that we have readily available, including ER visits, hospital, physician visits, and particularly pharmacy. Disease information will be gathered, number of diseases, state of the disease, and we will try to use some predictive modeling algorithms, but as most of you know, those are not where they have to or need to be in the future, but we will look at some of those, and hopefully through our own data and examining that as we go forward, we'll be able to get better at doing that. The RFP that's on the street now is divided into two parts: program management, which is interfacing with physicians and recipients in terms of recruitment and so on, and a systems management part, which is technology, in that we hope to have a web-based brief health record which will include recent claims data, particularly pharmacy claims data, current medications, recent studies, labs, etc. And that will be available to whatever provider is seeing the patient. I know I'm going through this a little fast, but Karen told me that I only had 10 minutes, so I'm kidding. How will providers be impacted? We'll use current Missouri providers, particularly FQHCs, RHCs, home health agencies, county health agencies, provider associations, and so on. In underserved areas, the vendor may have to hire physicians. We don't know how frequent that will be. We hope not very frequent. Physicians will be given an enhanced fee to participate in the program. Long term, we may look at some pay for performance. There are lots of issues there, we know, and we won't start out in that direction. We believe that the near-term impacts will basically be better health status for the chronic comorbid individuals. Long-term impacts, slower staging of kidney disease, chronic obstructive pulmonary disease. We hope to keep them out of the hospital and out of the ER. There was a lot of discussion as this was going forward whether we wanted to do a risk-based or a non-risk-based model. We elected to do the non-risk-based model. Here are some of the reasons and sort of the comparison between the two. Basically, the risk-based is pretty strict and formal. It's hard to change it as you go forward if something isn't going in the direction you expected it to go. And we think the long-term savings are better in the non-risk-based because we can tweak it, we can change it, we can have the guidelines up there, we can change those as we go forward. And so for those reasons, basically, we decided on the non-risk-based. We feel like this subgroup of patients we're talking about spend about $1.7 billion a year. We project the savings between 58 and 116 million, and we feel most importantly that this will help bend that trend line to a flatter level. This is a visual representation of that those savings. The yellow is the risk model savings. The purple and blue are the estimate. Somewhere in that range will be what our savings are going forward. The RFP is there. The pre-bid has been conducted. The final bids are out. We expect actually the return of bids in the first part of November, awarded in late November, implementation first part of '06. Again, we think this approach is consistent with the direction that we think Medicaid needs to go. It coordinates services to the need. In other words, it's sort of diagnosis-based, and the services come to the patient based on their diagnosis, not that because you're in a categorical group, you get a particular service. It's targeting disease with services not available to every recipient. It incorporates best practices and guidelines based on best practice. We're using increased utilization of technology for program management and provider service. We limit and prevent waste, abuse, and it targets the delivery to reduce the cost. You want to wait and do questions at the end? Or?
Yes.
Okay.
Let's do. Thank you, Mike. Thanks a bunch. Our next presenter is Donna Checkett from the managed care side of things.
Thank you. It's very nice to be here. Is this on in the back? Great. Okay. The future of Medicaid was the title, so I thought, well, that is really a wide open target. You could talk about almost anything, but I decided to talk about managing care for high-cost populations. I am really afraid that we have the old thing loaded, because you'll note that I have an NPA and an NSW, which I'm not a nurse practitioner, and I don't know what an NSW is. So we're going to find out what we see when I press enter. Whoops is all I have to say. Okay, a little history about Missouri Medicaid. Actually, I'd asked Karen for a little guidance, and she said, we'll talk about managed care. And when I was Medicaid director here, kind of the thing that I put in place and then did me in was the implementation of the managed Medicaid program, fondly known as MC+. And so the goals at that time were very basic. This is basic, managed care 101, controlling costs, improving access, improving and ensuring quality of care, establishing a medical home, and the program focuses on low-cost beneficiaries. So the program was always focused on TANF or low-income moms and kids. The program actually started in 1994. I look out and I see lots of people here who have been part of that, and I think we've all learned a tremendous amount in those years. And really, by all measures, Missouri's managed care program has been successful. This map indicates where we have managed care now, and with the exception of a few additional counties, this is basically the way the map has looked for about 10 years. It's the I-70 corridor. I think right now there's probably about 43 to 44% of the Medicaid beneficiaries in the state who are enrolled in managed care. One thing I think is very important is to note that with this model, when this program went into place, Missouri chose to have mandatory enrollment. And I think as we look at options and talked about with the future of Medicaid, you know, one thing to talk about is what is the influence of mandatory enrollment or not? Does that force participation or not make a difference? One thing it does is it gets you a lot of people in your program. Right now there are 7 health plans in the state participating, and very stable players. Most have been here in Missouri for a long time doing managed Medicaid. Cost avoidance attributable to MC Plus managed care. We got this from the Department of Social Services, so you know it's right. And I love the numbers, so I totally agree. And I think if you add it up, it's about $450 million in savings since state fiscal year 2000. Now, you might remember the program started in 1994, so there are actually longer savings over time. But you see very clearly that there are cost savings, and those cost savings are due to the way that the rates are set, and those rates, which must be actuarially sound, are nonetheless below fee-for-service. I love this slide. This is interesting because it shows us, and all of us who are concerned about quality in the future of Medicaid, should say, well, what are those HMOs spending their money on? Because there's always questions about, you know, the incentives behind managed care, and are people doing good things or bad things with managed care? And this slide shows us that there has actually been an increase since 2000 to 2005 of 85% to 89% of the capitated dollars being received by the MCOs are going for medical expenses. That means in 2005, 11% went for admin and whatever profit there was. So I think this is really important, and as a state and as policymakers, something to focus on, because when you have any health plan, but particularly managed Medicaid plans, coming in at 80% medical loss ratio, that tells you 20% is going for admin and profit. And personally, I think that's too much. So I love this slide. We also think that managed care has done very well. We have some things that we're able to demonstrate, improvements that have happened. Now, another reason why I love this slide is that it's from the Department of Health and Senior Services, so you also know it's right. And I say that not facetiously because we're not making these numbers up, and I think that's important when you're an advocate for a program. You know, other state bureaucracies are saying these are the programs, these are the changes, and some of them are very small. We're talking, you know, very minimal, 1.2%. Well, that's probably not even statistically significant. But a drop of 7.3% in inadequate prenatal care, an increase of 8.2% in first trimester prenatal care, those are statistically significant. They're beautiful numbers, and you know, when I look out and see Bill Kincaid and some other people here who were here on the ground, it says to me some good things have happened. Missouri Medicaid plans are accountable. We are subject to solvency requirements, thousands and thousands and thousands of report, and my favorite fact is that the current managed care contract with Medicaid includes over 500 must and shall statements, which means we must and we shall do these different things the state of Missouri and the Centers for Medicare and Medicaid are telling us to do. So we've saved money, we've improved care, and we must and shall do it 100% in the spirit of our contract, which we do. So what next? Now, I imagine by the time this panel is over, you're going to see in about 5 or 10 different versions. How many speakers do we have? At least all of us will have a version of this. But what is really important is that in state fiscal year 2004, The elderly and people with disabilities comprised 23% of the eligibles in our huge Medicaid program, but accounted for 67% of the Medicaid expenditures. And this chart, which is extremely detailed, goes into all the different places about where those costs are being spent, much as Dr. Ditmore indicated. The big costs are with the people who are not in any type of management, and certainly I know that's a goal of the Chronic Care Improvement Program as well. Now, over the course of this past year, Schaller Anderson, which is the company that manages Missouri Care, had a very laborious and painstaking process of getting data from the Department of Social Services, which we did get and we worked through, and really appreciate their help on that. And our idea was we just wanted to see what opportunities are there for care management and other savings that could be achieved for management of Medicaid. And this was really when all the big cuts were going on. You know, I just felt with so many people in fee-for-service who are so high cost, you know, were there other things that we could or should be looking at? And so what we've learned is that in the Missouri ABD population, which is kind of a national phrase, we don't quite call it that in Missouri, I guess it's PTD, a very small number of members drive a significant portion of medical claims cost. In fact, we see that the top 10%, which is less than 10,000 members, are driving 54% of the cost of the program. Now, these numbers exclude these numbers are medical claims only, so it's not pharmacy. And, you know, I think George has done a fabulous job on that. We were talking about medical claims only, and this is for the non-institutionalized population. So these aren't people in nursing homes. These aren't people in MRDD facilities. It's telling you there are some very expensive members, and there's not a lot of them, frankly, that I think would be areas where we would be able to make some changes. So how would managed care principles, and I said principles because I don't think it has to be capitated managed care, but how would those principles improve cost, quality, and access? In the managed care world, there are 5 things we do, and we do them and believe in them: case management, disease management, member profiling, provider profiling, and concurrent review. And that's kind of the guts of care management programs. I'm not going to read this all out loud because it talks through the different interventions and what the expected financial impacts would be. But I'll point out that, and I have to put my glasses on because I can't read this section, that on member profiling, a reduction of 0.5 per script, so a half a script per member, would translate to over $46 million in cost savings. And that could be something that could be done through risk profiling, and I know that's in the CCIP proposal. We would also be able to look at increase in the generic prescribing rate. Right now it's running about 58%, at least on the analysis that we got, and the health plans that in general manage Medicaid plans are averaging 65 to 75 or 70% generic. A 1% increase in generic prescribing translates to over $3.8 million in savings. So these are things that could be done to achieve savings. The final is a reduction in the number of days, lengths of stay in hospitals. Missouri Medicaid pays for on a per diem basis, so there's not an incentive to move people out. So there would be savings that could occur through concurrent review program. So what would happen? Aggregated 3-year managed care principles savings statewide could be as much as $361 million, or about 10% of the total Medicaid cost. This is a very broad brushstroke. I want to emphasize that. You know, obviously needs to be dug in much, much deeper. But the real point is that there are really potential to save money and improve care at the same time. So what could we do? As I basically said, we can realize both cost savings and improved health outcomes for those populations not now in management, not managed, whether through the CCI program or managed care or whatever. I do believe that many other states, most notably Arizona, which was referenced by Melanie as well, have a managed care program that includes high-cost beneficiaries. And I'm going to talk about one, and then I'll finish up here. Since 1986, the Arizona, what is called long-term care system, or ALTEX, has integrated all the covered Medicaid services into a single delivery system that is coordinated and managed on a risk basis. ALTEX is geared toward helping beneficiaries live independently in a home or community-based setting for as long as possible. In order to enter the ALTEX program, in addition to being on Medicaid, the recipient must meet what in Missouri we would call the nursing home eligibility criteria, the 18-point count, the which is now, is it 21 now? you have to meet that criteria. So these are the sickest of the sick. 70% of people participating in All-Tex in the state of Arizona are living in safe and appropriate non-institutional settings. Arizona is third in the nation in terms of the number of people in nursing homes. I should say, in other words, from the top, people not in nursing homes. And in 2004, an independent study of people in the Mercy Care All-Tex program found that 99% of the respondents were satisfied with the program overall. We have outcomes from the fully integrated system in Arizona. Inpatient costs are down 21% over the same quarter 2 years ago. Readmission rates, and this is because of a very concerted effort that's been going on inpatient readmission programs. So readmission rates have dropped, and members in nursing homes cost almost twice as much as those as home and community-based settings, as compared to those who, of course, are in the home setting for All-Tex. This is where the error is. It says that member satisfaction exceeds 90%. Actually, the final from the state was 99%. And most significantly, not most significantly, but very significantly, the state savings averaged 16% under fee-for-service for similar populations. So it's a very interesting program. It's gotten a lot of attention through the years, and when Tony Rogers, who's the Medicaid director in Arizona, was testifying before the Medicaid Commission yesterday, in fact, one of the things he talked about is this program. And this is why. Because the MC plus population, the aging of the Missouri population, if you look at the census data, you'll see that between now and 2003, it doesn't look like a whole lot of people are just packing up pickup trucks and moving to Missouri. If anything, it looks like people are moving away from Missouri. And what is growing is the 85 and over population. So that you see that between the year 2000 and 2030, the Census Bureau is predicting a 57% increase in the number of people aged 85 and over. And those are the people who can be in a program like All-Tex. Those are the people who will consume the greatest percentage of our health care dollars. So I will close with that and ask you to think about that until we meet again and have questions. Thank you.
Dr. Astrike.
Thank you, Dr. Esson. When talking about the opportunity to be with you today, Karen asked for me to spend a little time on pharmacy, and I really appreciate the opportunity to do that. It seems like one thing we've been talking about more lately than pharmacy in general is MMA, and I'm just about tired of that discussion. So I think in the future we'll have an opportunity to revisit that, and hopefully you'll have a better basis to judge the efficacy of that. I have about 30 slides, and I'll go through them very quickly, but there's some key points that I want to try to impart to you today, and that's basically how we manage a pharmacy program and what we've done in Missouri over the last 4 years to try to manage the Medicaid pharmacy program. The cost drivers for a pharmacy program are the cost of the prescriptions, as you might well imagine, the number of prescriptions that an individual uses, or a per member per month sort of measure. That's dependent upon the mix of the recipient population and the mix of users versus eligibles. As we have the ABD or the PTD population in the fee-for-service program, and this all will be on the fee-for-service program, that tends to drive our relative number of users up as well as our utilization. And you'll see an opportunity to envision how that sort of impacts the whole program. The graphics that I would use here, the take-home message from the average script price is if you look at the relative slope when we began about 3 years ago, and look how we have sort of bent the trend, as Dr. Ditmore was referencing the goal to be. These different graphics here represent our total expenditures, total number of eligibles, and of course these are our folks that are our big drivers, or our permanently and totally disabled population. And as we look at that from a perspective of a cost per eligible per workday rather than user per month, we try to increment it down a little bit lower so you don't have as many little jiggles in the graphics. And for that reason alone, you could take this and multiply it times 25 and have a PM. Again, you see the opportunity for that slope to come down. And that is a meaningful opportunity when we look at the savings over the program. We talked a little bit about the Medicaid eligibles and the relative growth. You see here where we actually dropped the number of eligibles, and we Dr. Edson mentioned why that happened back in the 539 drops. But I would point out to you, if you look at our fiscal year 05 group of eligibles, we saw a 12,320 growth. In our permanently and totally disabled, we saw an increase of 12,658 individuals. Our elderly increase was 2,963, and our overall decrease was 3,300. So what I'm doing basically is taking these healthier folks, that cost me on a scale of 1 to 10, 1 to manage, and I'm trading them for the permanently and totally disabled population that cost me almost 10 times as much to manage. So that's one of the stresses as we look at that opportunity. This is the little Barney purple lines, or our budgeting lines, and you can see the precipitous drop here that will occur with the Medicare Modernization Act. But you can see as we're going over the current budget period that we're hanging in there pretty close. Generally what you'll see is that we'll have these little dips over the last, first year we actually saw a lapse in dollars budgeted. Last year we saw a small lapse. This time I'm hoping that we can, with MMA coming on board, that we can at least be even. That's going to be a major challenge, however. Then what is the overall impact over the last 3 or 4 years? What we've done then is to take the graphics on the per member per month and the average script price and project what would have been had we done nothing to manage the program, and then taken those same particular entities and graph those against those and slope them out over the whole period of time. And then the little take-home message is the gap between those two. That's about $1 billion that we've been able to cost avoid over the last 4 years in the pharmacy program. The revenue strategies, if you've ever talked to a lot of Medicaid folks, one of the first things you hear is that if you've seen one Medicaid program, you've seen one Medicaid program. And it's that way in Missouri, too. We've got some unique things in the pharmacy program in Missouri. Some of those will actually impact the overall dollars that we do spend in the pharmacy program, because we aggregate all of the pharmacy purchases under the pharmacy program. And we also have a provider tax. So if you would look at the data that we submit to CMS, and subsequently that's graphed in the Kaiser reports, every one of our scripts is really overstated by $3.95 that's related to the implementation of the provider tax. And if you look at the overall opportunities there, that sort of skews our numbers away. So the message is, we will manage against national averages and manage against ourselves, but it's really hard for us to manage against another Medicaid program. Additionally, in the rebate section, we've aggregated all of the purchases, as I mentioned, so that the medications that are used in outpatient settings are all channeled through the pharmacy program, so we can realize the savings for the rebates, the federal rebates that are associated with that. So if you're a practicing physician, you may wonder, well, why do you have to bill on a pharmacy claim form in order to be reimbursed for medications administered in your office? And that's the very real reason. We save almost 25.5% on every dollar that's billed through the pharmacy program on the basis of the rebates and supplemental rebates. We implemented the supplemental rebate activity about 14 months ago, and we're seeing about a 6% savings overall on about 80% of our total purchases in that area. The basic product pricing, I'll let you read through those, but we'll look at each of those and the impact of those a little bit in rather a quick fashion, actually, but look at how each of those have impacted expenditures over the period of time that we're looking at. Missouri to national trends, I mentioned to you, that's one of the ways that we try to benchmark ourselves. For the first 6 months in calendar year 05, Missouri has experienced an average 2.2% increase in average script cost. And if you can see the graphic from the Wall Street Journal in August, the overall average nationally is running, it looks like about 5.5% to me, or somewhere in that range. So we're about half what that particular number is. If you look at the spending associated on prescription drugs last year from the Wall Street Journal, it was a 7.2% increase. In Missouri, we experienced a 4.02% increase. So again, holding that down as well in the mix of patients. We use MAC pricing, which is maximum allowable cost. We have the opportunity to use, in some cases, federal upper limit pricing, But this is the mechanism by which we mandate the utilization of generics. As Donna said, we have about a 58% utilization of generics. If you look at the opportunities that are out there for generics to be used, we're running about a 93 to 94% generic utilization. One reason that we'll never get to 100% is that there are a couple of very key items that we actually encourage the use of a trade name product, and we do that because the net cost to the state is actually less with rebates and supplemental rebates for the trade name product than the generic. For the first 6 months after an introduction of a generic medication, frequently you have the opportunity to see about a 10 to 20% savings over the generic over the trade name, and that actually gets much, much better when more folks are able to come into the market after that first 6 months. In this illustration, we're seeing the utilization of MAC pricing that shows about a 78% off of wholesaler acquisition cost, which is our base now, as opposed to using the trade name product at the lower level, it would be an 82% savings. We use the system, Heritage Information Systems, as an overlay to our way we adjudicate claims. For those of you not familiar with pharmacy claims, they're adjudicated on a real-time basis. That opportunity allows the claim to be adjudicated in about 3 to 4 seconds. In other words, when the pharmacist gets all of the information in at his pharmacy, pushes the button enter, goes through a switch to our adjudication system, goes through clinical edits, goes through financial edits, comes back in less than 5 seconds. We have that opportunity to use the Smart PA, which basically, if you go to a straight prior authorization process, 100% of your opportunities would require a call center call. What we've implemented is a program that will allow 65% of the overall opportunities to be adjudicated online, real-time, no call, no hassle to the provider. This is what I say is our actual failures, if you will, and those failures are the ones that were not allowed to be adjudicated online, and the failures are the reason for that non-allowance is that we don't have all of the claims, all of the medical claims up to date in our system. Medical claims, as you know, are not adjudicated real time and sometimes lag the other claims from 45 to 60 days. So if we can get to the point that we have the opportunity to do real-time adjudication of all the medical claims, that'll go much more quickly. I give you the opportunity to look at the difference between prior authorization and clinical edits. Karen has told me I've got 5 minutes, so I'm going to have to hustle along through here a little bit. The step therapy example, we had an opportunity to utilize reference products and increase that opportunity in the non-sedating antihistamines about 400%. You can see the graphic increase in the number of times the reference product was used, but the take-home is the decrease in the PMPM, and the realization of that is several $million. Actually, we're at about $60 million over that overall progress. This one's going to be hard for you to see, but the take-home here is these are all on our website, and the website address is there. We have about 50 different clinical edits and step therapies. We would encourage you to take a look at those to see how, in fact, we adjudicate those through the process. The denial criteria is on each one of them, and the approval criteria, and again, our goal is that that's done transparently. We also have a pharmacy-specific website, and it's not restricted to pharmacist use, so feel free to look at it if you wish. All of our PA and DUR board activities are in the lower part of that, and we give you an idea of some of the evidence that we use in the establishment of the product. Dr. Ditmore mentioned a little bit about the BPMS program. About 30% of our expenditures are for behavioral health meds. Antidepressants are 63% of that. What we have done is to do a retrospective review of these and tried to work with the physician base to understand the issues associated with that use. You can see, again, how they're broken out graphically in our savings. We picked particular items that we think are not good ideas, polypharmacy indicators. You can see the top of that would be 3 or more drugs within an atypical or antipsychotic, which clearly is beyond best practices. These 2 items are the ones that we'll go through. You can see if we looked at all of our number of mental health patients, we found one guy was taking 12 different behavioral health medicines alone, not counting his physical health medications. Clearly the opportunity for drug adventures for him was very, very high. So anything really above this area, we think that there's a significant problem associated with it. What I'd like to show you is the impact of the program when we look at the kids. We're particularly sensitive to the children, and especially those receiving 3 or more behavioral health drugs concurrently. We used a partnership with Comprehensive Neuroscience to review some of these. We've gone back to Mercer to have them validate the savings that we've seen there as well as the implementation, and we've checked for the regression to the mean for the data as well. If you look at these 2 opportunities, you'll see that after the interventions, we've had a relative decrease. The take-home here was 46 there and 43 if we look at the kids alone. But the take-home is that we bring more kids into the system and more prescribers, so the job's never done. We had thought that perhaps we could find a leveling of that, but I think what you find is that the system is very fluid. When we asked Mercer to look at these trendings, we believed that we would see savings. We wanted to look at what the projections were, what we would see from the individual data, and then what we experienced budget-wise. And this was just the antipsychotics alone. Looking at that and the opportunity, this is after 3 interventions with the letters, and the overall savings in the antipsychotics was $3.6 million. When we look at it from our budget perspective, actually they all proved to be about on the same target. We saved almost $8 million on that particular non-invasive retrospective review of drug therapy. The one other study that I'd like to show you before closing is an opportunity to see what the other costs are. You know, our idea was that if you get the right medications and you reduce the number of medications, especially for that poor individual that was on 12, that their overall health care status would improve. And we did a study both that was done on the same program in Utah and the Missouri data as you see. And you can see the p-values are relatively good. And you can see that the savings represent those in the intervention group of 7.3% or $1,238 on pre and post exposures on 1,900 patients. So just in psychotropic medications alone and other health care costs, the reduction of those did not, as some folks would have told us, increase the number of interventions in the tertiary care setting, but in fact reduced the overall cost of the program. We have a few opportunities to work on here for 06. I'll not go through those for fear that one of them I'll be behind and Dr. Ditmore will find out. But there are at least 10 of those that we're trying to get done this calendar or fiscal year rather. And I'll close there.
Thank you very much.
Thank you.
I know. I'm just going to get rid of this for you. I will open this. Get rid of it. It's Steve rolling.
I don't have a PowerPoint. I saved Karen some trouble. If Dwight doesn't have to wear a tie, then I don't have to tie my tie all the way to the top. So those of you who've been sitting all day with your tie up, bring it down.
I didn't make the dress code.
Okay. What's the future of Medicaid in Missouri? Well, in my last job, when I was the director of the Missouri Department of Social Services, I would have had to answer that question with a bunch of specific, short-term answers dealing with a whole lot of details that all fit into a budget that we were in the process of discussing with the governor and with the legislature. I am no longer the director of the Missouri Department of Social Services. So today, in my new role with the Healthcare Foundation of Greater Kansas City, I want to take a more big-picture, long-term perspective in answering that question. On this panel today, as you've already seen, you have some of the smartest people in the state of Missouri, and I would argue some of the smartest people in the country on Medicaid. We have a wonderful Medicaid program administered by very, very smart people in the state of Missouri, and we should be proud of that. I'm going to make 2 assumptions that I hope you agree with. First, we cannot talk about the future of Medicaid without also talking about the future of health care in general in the United States. They are interlinked. We have a health care crisis in America. The health care system is broke, and Medicaid is part of that overall health care system. We cannot find long-term solutions to the Medicaid program unless we find long-term solutions to the U.S. health care system. both in the public and the private sector. The second assumption is the Missouri state employees who process the Medicaid bills, who implement and communicate legislative policy decisions, and who conduct eligibility tests to determine eligibility for Medicaid clients are some of the most dedicated, hardworking, honorable public servants I've ever had the privilege to be around. Across the country, the Missouri Medicaid program is seen as a model of efficiency that many states are trying to duplicate. To be sure, our Medicaid program has some challenges, but our state employees should be treated as a valuable resource and part of the solution rather than a cause of the problem. To paraphrase Dr. Gardner, oftentimes our best opportunities are usually disguised as insolvable problems. Controlling the cost of quality health care while making it more accessible to everyone seems to be an insolvable problem in today's world. For example, our national health care spending is about $1.8 trillion, more than 15% of GDP, the highest of any nation in the world, and still we have approximately 46 million folks uninsured. U.S. life expectancy ranks 25th in the world, even though we spend more on health care than any other nation in the world. In the United States, we spend about 95% of our health care dollars treating illness and only 5% on preventing illness. In 2000, 69% of U.S. businesses offered health care insurance coverage to their employees. In 2005, that number was reduced to 60% of U.S. businesses offered health care insurance coverage to their employees. And according to national and state polls, this number will continue to decline as health care prices increase. According to Kaiser Family Foundation research, since the year 2000, employee health care premiums have increased 73%. Annual average premiums for family coverage reached $10,880 this year, eclipsing the total gross earnings for a full-time minimum wage worker, which is $10,712. So if you're a minimum wage worker, you'd have to give all your salary to pay for family health care. In Missouri, we spend about $5 billion per year to fund the Medicaid program. In addition, in Jackson County alone, where I'm from, an additional $70 million is spent to pay for uncompensated care by Jackson County hospitals. Yes, oftentimes our best opportunities are usually disguised as insolvable problems. As we know, as we've heard today, every state in the nation is trying to figure out what to do about this. This is tough work, and so I like to refer to my favorite philosopher. We heard about Cedric the Entertainer this morning. My favorite philosopher is Yogi Berra, the baseball player. And Yogi once said, predictions are difficult, especially if you're talking about the future. So here's my predictions. I seriously doubt that we can cut benefits or reduce services enough or increase taxes enough to totally solve this problem without drastically changing the system. As a nation, we already spend more than any other country in the world on health care. It seems to me that the more Americans spend on health care, the greater number of Americans become uninsured. When I was at school at the University of Missouri, I was told when you spend more money to correct something, it should get better. And if improvements are not made, you should look at spending your money more wisely. On the other hand, I believe cutting federal and state health care benefits or services to the poor is a short-term financial solution that will not show long-term financial and health-related results within our present health care system. People are going to get sick, and while the state and federal government may choose not to pick up some charges they pay today, under our current health care system, insurance companies and businesses will have to increase their premiums and prices in order to pay for necessary medical treatment for their customers and employees. Eventually, this cost will become so high that a majority of businesses may no longer offer health insurance, and insurance premiums may be too costly for most Americans to afford. We then will have more uninsured in our current health care system may be brought to its knees. We have to simply change the system. In my view, Missouri is, and I think it's recognized by folks around the country. When I was director, I traveled a little bit and talked to a bunch of my fellow directors around the country. And Missouri is recognized around the country as a leader in having an efficient and effective Medicaid program, thanks to many of the people on this stage. Missouri is a national leader in maximizing federal matching dollars for Medicaid. We have instituted managed care. Georgia has done a fabulous job of controlling pharmacy costs, as you just heard about. We're developing new ways, thanks to Dr. Ditmore, of saving money through chronic disease management. And we have aggressively, for many years, been pursuing fraud, waste, and abuse from both providers and clients. Yet our health care costs continue to rise, both for Medicaid and for health insurance in general for all Americans. We have to do more. We need to emphasize prevention and health education more. We need to encourage people to exercise more, eat less, and to quit smoking. It has been estimated by the Missouri Department of Health and Senior Services that we pay approximately $1.6 billion per year in health care costs, both in the public and private sector, because medical problems caused by being overweight, heart disease, type 2 diabetes, asthma, arthritis, breast cancer, etc. It has also been estimated that Missourians pay approximately $1.7 billion in medical costs, both public and private, because of medical problems caused by smoking. And 75% of Missourians don't smoke. So together, as taxpayers in Missouri, we're paying over $3.3 billion to treat illnesses that we can cure ourselves if we watch what we eat, exercise properly, and don't smoke. We know how to revolutionize the healthcare system that would save billions of dollars and at the same time improve overall health for our citizens by simply encouraging Missourians to change their personal habits and emphasize prevention. Remember, as a nation, we spend only 5% of our healthcare dollars on prevention and the rest on treating illness. We talk a lot about waste, fraud, and abuse. Frankly, we are spending much time in Missouri on finding fraud and abuse from clients and providers, which I think is very appropriate. But I think the really big dollar savings can be achieved by cutting back on waste and duplication. From my experience, we can both save money and improve patient care if we reduce or hopefully eliminate waste and duplication. Let me give you a personal example. About 2 years ago, my father died from melanoma. Prior to being diagnosed with melanoma, he had open heart surgery. So for the last 4 years of his life, he had 2 heart doctors. He had 2 surgeons, 1 family practice doc, and 3 specialized cancer doctors. All treated my dad with respect and dignity, and I was so grateful for the services they provide to him. However, at one time, my dad was taking over 30 pills daily prescribed by various doctors that he was paying for out of his own pocket. I don't blame the doctors. They were each trying to provide my father with the best possible care they could with the information they had in front of them. Every time my dad went to a different office or a different doctor, they wanted to do their own blood work, their own MRI, CAT scan, et cetera, et cetera. We tried to get copies of each medical treatment and take it to the next office, but we were not always successful. My dad was sick and old, and trying to keep up the paperwork was oftentimes more than he could handle. Somehow, we need to get healthcare more married to technology. We are wasting billions and billions of dollars because of duplication medical tests and prescription drugs. Some national experts say that between 35 and 40% of all medical test procedures are unnecessary. We have some integrated electronic medical records models that we can learn from. The U.S. military has one record for each patient. The Kansas City company is developing a laboratory information technology system to use by the Department of Defense in more than 100 military hospitals and 400 clinics in the U.S. around the world. In Kansas City, many of our largest employers have joined forces to work together to develop a system to integrate medical records of their employees with local doctors and hospitals on both sides of the state line. There are several small communities located throughout the United States that are forming coalitions of doctors and hospitals, insurance companies, and employers to share medical records online to improve the quality and safety of patient care by reducing errors and wasteful spending. Obviously, there's no silver bullet to solving the current healthcare crisis, but we do know the leading cause of premature death, which is obesity and smoking. And we do know that through health education, we can significantly reduce premature harm caused by personal life choices. We know we can dramatically improve patient care and stop wasting money by duplicating tests and prescriptions if we develop an electronic medical record system. In addition, there are many communities around the country where doctors have developed a volunteer system whereby every doctor takes a specific number of Medicaid or uninsured patients so that no one doctor in the community has to financially bear more than their fair share of what every person in the community is provided, whether they have insurance or not. In other words, you have 50 primary care docs. They all take 10 uninsured patients. Therefore, all of them take their fair share. What happens in many communities is that once it becomes known that you are a Medicaid doc, that's all you get. And so there's communities around the country that are trying to work on this to figure out how to do it better. Now, I know these are big picture solutions, and they are not new ideas, and these ideas alone obviously do not represent all the things that we need to do to modify our current healthcare system. But each of these solutions, I think, is within our reach if we target our financial and brain power resources on these matters. We know how to prevent spending billions of dollars for treating illnesses, and we know how to eliminate billions of dollars of waste and duplication while at the same time improving patient care, safety, and access. Let's take advantage of this knowledge and change the healthcare system as we know it today before the healthcare system becomes unavailable for too many Americans. Controlling the cost of healthcare while making it more accessible to everyone no longer seems like an unsolvable problem to me. Rather, I consider it a goal that we must achieve in our lifetime. Every person in America should have access to quality health care. For this to happen, we need leadership from citizens, as we talked about this morning, from Dr. Satcher and other speakers. It's up to us to do our part. It's up to us, those of us who are on Medicaid, those of us who are citizens who are not on Medicaid, to exercise properly, to eat right, and to quit smoking. It's up to our legislative leaders, our political leaders in Washington and state capitals all across America. And we often know that the will to persevere is often the difference between failure and success. I hope our political leaders will seek long-term solutions that actually improve the quality and access of health care for all Americans. Our foundation stands ready to help. Thank you.
Dwight?
Thank you, Doctor. I appreciate the opportunity to be here and to share some thoughts with you. And realizing as I looked at the agenda, we probably needed to boil this down a little bit. I brought along a special handout. If you have it, I think I'll look at it for a few minutes and then call your attention to a few slides in the larger presentation that is also, I think, included in the packet. The document that we distributed, the first section is labeled the uninsured, or the partnership. And what I would like to share with you, I've identified probably what I think are 4 challenges confronting the Medicaid program and the healthcare system. And I think in the spirit of through 2025 are these problems and challenges that we can solve or sustain through that period of time. The first one is a graph that simply says over time we have been very clever in Missouri, as Steve mentioned, in figuring out how to use state dollars and especially provider tax dollars to maximize federal funds flowing into Missouri. I think, in fact, I don't have the graph with me, but I think there are only 5 or 6 other states who put less general revenue, pure taxpayer dollars into their program than Missouri, and a whole bunch of states that pull a lot more general revenue into the program. This partnership, I was thinking how fortunate we have been over time to have the right Medicaid director at the right time. Donna Checkett and the crew that she worked with knew the finance side of Medicaid cold, and they worked with us to create the first provider tax, and I think we're now up to, what, 4 or 5 provider taxes. But Donna held our hands as we walked through the hospital provider tax, and the net result of that is with our various provider taxes and some other state funds, we're funding approximately half of our Medicaid program through those mechanisms. I think if I were those of you who are legislators in our audience and from the executive branch, I would be asking the question, can we sustain this through 2025? My personal opinion is I think the answer to that is yes. But what I would caution is that this has really become a mature program, in my opinion. I doubt that there are many more provider taxes that we will be able to sell to the federal government, though I think we might slip the HMO tax in under the wire here. I noticed we're in the markup in Grassley's bill. That's good news. So the provider taxes are very important to us going forward through 2025. If something would happen and we would let the federal government begin to severely restrict or eliminate this program, we have a serious problem on our hands in Missouri. But I just would like to say that we are committed over time to working with the state to continue this partnership because we think it has been very productive for our state. Now, when I said we've been fortunate to have the right Medicaid director at the right time, I think having Dr. Ditmore on board today, the way we're going to make this program work in the future and to try to maintain its viability and to continue to cover the vulnerable populations that need to be covered will be through the medical management techniques that he outlined to you in his presentation. We're very much in support of heading in that direction, and his clinical knowledge is very important to the future of this program. So I think over time, spanning the Ashcroft administration to the Blunt administration and Steve in there with the Holden administration, we've had good people who understood the program in the way that we could maximize it at the point in time that was appropriate. Probably, I would echo what Steve said. We really have a health care system that we can barely afford, and as you look at the demographics going forward, it's really kind of frightening. I quite honestly, this is probably more of a personal opinion than an MHA opinion, but I agree with Steve. I don't think we can raise taxes enough, and I don't think there are enough people that we could remove from coverage to really make this program viable, and the better management of care that leads hopefully to better outcomes is the key. Well, we do have a growing population of uninsured, and the thing that scares me is the statistic that Steve pointed out, not so much the cuts that we'll experience over the next 2 years in Medicaid, and I tried to quantify them. In our study, we think there are about 450,000 uninsured. We think that will grow to a little over 500,000 as a result of the Medicaid cuts. But when I look at the long-term, big picture consequences for our health care system, and I see employers bailing out big time, and I understand that some large employers are offering a health and benefit. They're being challenged by other large employers who don't offer a decent health benefit. And in that kind of marketplace, what's going to happen? Employers are going to keep trimming health care costs to be viable in the marketplace, and it's going to put a lot of pressure on the health care delivery system and on the state and federal government. I would applaud President Bush for having put forward a proposal. You know, some say, Steve, that we're really on a downward slide toward the Canadian model, that ultimately everybody will throw up their hands and we'll just have one government-run system. I think what I see when I look at the President's proposal, for instance, a new program evolving at the federal level for the working uninsured, I think that leaves Medicaid dealing with the most vulnerable populations, the elderly, the disabled, and the children. And I think the Medicare program continues in its form for access to care for the elderly. So I really kind of see three programs evolving, with the first one being pretty much ill-defined, but the President's proposal is to use tax credits. So take the money, give it to the low-income population, let them buy health care coverage through a purchasing pool. But clearly, in this dynamic, with employers and declining coverage, we have to begin to look at it as a great societal need, and how do we address it. Finally, I kind of want to challenge the conventional thinking here on how we're going to manage costs, and I have two graphs for you pointing out essentially that we have $280 million in general revenue being spent on children and adults, and $717.9 million being spent on the elderly and disabled. When you look at the breakout of those general revenue dollars by populations, and if you look at those two graphs, the thing that catches my eye, one of the biggest problems we have in our Medicaid program, is the clawback. Our estimate in the 2000 budget cycle, the single biggest general revenue expenditure will be the transfer of state funds to the federal government to help fund the Medicare prescription drug program. And there is so little discussion around that in our society that I find that somewhat frustrating. I think that we need to support the federal government. We need to get this prescription drug program up and running. But I would hope over time that the states can begin to earn some relief from the clawback program. Essentially, the clawback says, well, George used to spend $500 or $600 million on prescription drugs for the dually eligible elderly and disabled, and those folks have now transitioned over to Medicare, and so the state should continue to pay its fair share of the cost of that program. Well, what you and I know is that in good times, the state revenues are barely adequate to sustain our programs, and in bad times, we have to cut programs because we don't have the ability, as the federal government does, to do the deficit spending. So this is clearly a programmatic change at the federal level that needs to be revisited sometime in the next 2 or 3 years, because the states simply cannot afford to continue that level of support for the Medicare prescription drug program. Those two graphs, I just simply would point out to you, the single biggest general revenue expenditure may, in fact, be the clawback. The second biggest is the managed care payments, so that's money already being paid out for managed care. I think third and fourth, in-home care and nursing home care, general revenue. Clearly, as you flip to the last page, the aging of our population, and Donna mentioned it as well. And I looked at a different cross-section. I looked at those 65 plus. I was intrigued that in 2005, we have almost 775,000 people over the age of 65. By 2025, that will increase to 1,258,000 people over the age of 65. If they continue to use long-term care services in the same proportion as they do today, and if you look at pages 8 through 7 in the handout that you have, or 8 through 17, you'll see that the elderly will grow from about $1 billion to a $3 billion program, the disabled from about 2-point-some billion to over $6 billion in costs. Clearly, our society needs to have a conversation about long-term care, who pays for it, where we receive the services, and ultimately, in my mind, at the federal level, we need some form of tax credits available to encourage more people to buy long-term care insurance so that they can cover their own costs as they age. It is a bubble in our population. It is going to challenge us in every sense of the word in terms of our ability to sustain this program through 2025 and beyond. Thank you, Karen.
Okay, we can take, we have some time, not a lot of time. We have about 10 minutes for some questions. Dr. Ross.
I thought that was a great presentation. I must comment on the focus on tax credit. I thought that was relatively balanced until you mentioned that. I think it's important that we put all this in perspective because we're really going to take a more comprehensive, unbiased look at reforming Medicaid. And the audience should know that two very capable organizations, the Kaiser Foundation, as well as Ken Thorpe, a well-respected economist and director of health policy institute at Emory, documented that tax credits alone will only reduce the number of uninsured by at most 4 million. That's a very modest reduction, and ultimately the patients who would benefit the most will not be able to sustain the significant benefit of tax credits because of then those even purchase tax credits. So I wanted to have a little bit more balance if we're going to talk about that sort of political opportunity.
A fair comment, and I probably should have been clearer. What I was trying to point out is that I think we're going to evolve into we'll have a separate program for the working uninsured. I am not exactly certain in my own mind as to what the details behind that will be, and was simply pointing out that the President put about $77 billion over 10 years in the budget to start that debate. But I would agree with you, there are multiple ways to tackle the problem. But I wanted to highlight the growing number of working uninsured people and would like to start a debate about how we try to provide some coverage to that population. So I understand there are other ways we could do that.
You in the back hear the question, Tim? Did you hear the question? Did you guys hear the question? Okay, all right. You're just looking at me. Okay. Other questions?
I don't.
The question was the question was about when Dr. Ditmore was talking about, I think it was the CCIP program, wasn't it?
Yeah.
And he was saying that it would include, as a vision, include federally qualified health centers or community health centers and rural health clinics, and specifically mentioned rural clinics. And the question was about what about urban clinics? So.
No. Is this on? Does that work? No. It really involves all Medicaid providers. It involves all Medicaid providers for fee-for-service. It has the FQHCs and the rural health clinics have a high percentage of Medicaid patients, and so, and they're mandatory. It's mandatory that we pay for those services. So when we roll this out, they will be identified as likely to participate in the program. But we'll encourage all Medicaid physician providers to participate in the program, whether they're urban, rural, or wherever. Yes. Maybe I don't understand what your problem is.
Maybe we can do that offline. Is that all right? Okay. Can we do that afterwards? Other questions?
And I don't know what your issue is, but the federally qualified health centers, examples of those, and it's a federal nomenclature or federal phrase, but for instance, Grace Hill House in St. Louis or Swope Parkway in Kansas City, those are federally qualified health centers. So they're certainly urban health centers. I think it's just a federal phrase is what Dr. Ditmore used in his presentation. And similar centers that aren't in urban centers are not called federally qualified health centers. They're called rural health centers. And it's really just a federal designation. So just that, I think the major urban health centers in the state are FQHCs and will certainly be encouraged to participate.
My question is regarding the managed care. And I'm wondering, in the studies you've done, if you've looked at a comparison of costs of utilization and duplication of services between recipients in managed care versus fee-for-service, and if there's been any cost savings there.
The question was utilization and duplication of services, managed care versus fee-for-service, if any studies have been done, any evaluation of that.
In Missouri, the health plans would not have access to the fee-for-service data to be able to do that. So I don't know unless Dr. Ditmore or George Astrike could address that. There are other studies done, nationally, and we have lots of information about utilization, but not anything that's a specific comparison to fee-for-service that I'm aware of in Missouri.
Some of our new decision support information that we're using does allow us to do comparisons of both utilization, specific services, ER visits, and does it in a band by band on the relationship between the managed care organizations and the fee-for-service program as a freestanding program. Now the problem is the encounter data to support that isn't broad enough to really look at it in detail yet, but we're certainly aware that that's an interesting topic and should be a benchmark of comparison, and we'll be looking at that as we grow our data warehouse a bit.
Jean?
You projected some savings in the CCIP program. Where did you get your data on which you could project savings?
The question was about projected savings in the CCIP program and kind of source of data from how that conclusion was come to, I guess.
We used a combination of estimates, one from our current disease management program, and we used what we had seen from national efforts along the lines of the McKesson progress in Washington that Melanie Renchen and some of the other sites. We think that the savings are at minimum 5%, likely to be 7%, and hopefully 10% as the program matures. And clearly those are not good, well, or evidence-based studies of the program, because to be quite candid, the data isn't there yet. So that's the end answer to the question.
For those in the back there that couldn't hear, the discussion was around the difficulty in projecting savings in the future around disease management and chronic care. It's well known. Other questions? Okay, going. I want to make a couple of announcements. The networking reception is next door, and please feel free to go over there if you've signed up for that, or maybe if you haven't. I just wanted to tell you to please fill out your evaluations, particularly if you want to get continuing medical education or continuing nursing education. And also it's very helpful for us as we plan next year's summit. And I think hopefully on the evaluation form we have a spot for writing in ideas for next year. We have a few of our own, but we'd love to hear from you about what you'd like to hear about next year as we continue this dialogue amongst our key health policy stakeholders. And then again, next year, it's October 27th here at the Capitol Plaza Hotel. So please put that on your calendar because we'll welcome your participation. And thank you all for coming.
A couple of quick things. Let me just echo what Karen said this morning. It's really gratifying to see so many people attend this conference this year and so many stakeholders. I guess we're all stakeholders in these debates. And so what we do with this now depends on us collectively to continue this discussion. I want to do two other really quick things. One is just on behalf of Karen and myself and Gwen and Stan to thank Pat Hubbs. I think Pat is probably out there, but if you'll all say thank you to her for arranging all logistics and making this work, that'd be great. And her staff. And then finally, there are several students in the room, and I'm a professor, and I guess I'm always going to be a professor. And most of these students are here because they're interested. They want to learn about these topics. They want to help us as we age and we get tired of working so hard. And so if they would at least stand for just a second so that we can see who they are. I know you are. I'm going to point you out by name if you don't stand up. I know you're all around the room. So please stand up. And thank you for being here. We appreciate your contributions. All right. And we invite you all to stay for this networking reception again and look forward to talking with you there. Thank you.